Welcome, everyone, to the University of New Mexico Law and Mental Health Series, weekly discussions of practice and science featuring experts in behavioral health and the law. This series is run by the Division of Forensic Behavioral Sciences of the University of New Mexico's Department of Psychiatry and Behavioral Sciences in support with the New Mexico Behavioral Health Services Division. I'm Anthony Perillo, the Forensic Psychology Training Director here at the University of New Mexico. For our talk today, if you have any questions for our presenters, make sure you enter them in the Q&A box. You can enter those anytime you feel comfortable, but do know that we hold them until the end. Also, we try to get to as many as we can, but oftentimes it's not possible for us to get to all of the questions. If you are pursuing continuing medical education credits, there will be a sign-in sheet posted in the chat box shortly, or right now. And then also if you're pursuing APA continuing education credits, there will be a link posted in the chat box for a survey that you'll complete. That'll be posted in the latter portions of the talk, so keep your eye on the chat box as the presentation is drawn to a close. Make sure that you open that link or at least bookmark it before you leave the webinar. And after you complete your survey, make sure you save the certificate because we don't have access to those completed certificates after the fact. The recording for this week's talk should be available on our YouTube page later this week, and the PowerPoint slides accessible for people that have registered for the series. That will also be available later in the week. As a heads up, next week, we have Dr. Meena Rutkalkar, who will be discussing practical strategies for enhancing cultural responsiveness and forensic assessments. But circling back to this week, I'm excited to introduce you to today's speaker, who'll be discussing the past, present, and future of mental health courts. This is Dr. Kevin Baldwin. Dr. Kevin Baldwin is a clinical psychologist and senior researcher for Applied Research Services in Atlanta, Georgia, where he provides criminal justice research and policy analysis nationally. Dr. Baldwin is also the director of forensic services at the Highland Institute, conducting forensic examinations for state and federal courts and for probation and parole authorities, serving as an expert witness in both juvenile and adult courts. He's a frequent presenter at regional and national conferences and has provided training and technical service to treatment and court staff nationally in a variety of settings. Dr. Baldwin serves on the faculty of the National Drug Court Institute and the National Judicial College. He's earned his Ph.D. at Georgia State University after completing an adult forensic internship at the University of North Carolina at Chapel Hill School of Medicine and the Federal Bureau of Prisons. So Dr. Baldwin, Kevin, on behalf of the University of New Mexico here, thank you so much for sharing your expertise with us. And we're very thankful for you joining and talking about an issue that I've long considered like the true nexus and intersection of the mental health and the criminal legal systems. I'll go ahead and throw it over to you.
Thanks so much, Anthony. Thanks for having me. Thanks for all you do to put this together. I've attended, I think, about 75 or 80 of these seminars, and they've been incredibly helpful. So really appreciate it. I hope I can live up to what your past presenters have done. Thanks everybody also for attending. We're going to talk about mental health courts today. And we're going to cover a couple of things at the beginning, which are fairly typical. And this is something that Anthony just mentioned. That's how to get CEU credits. All the information is right there. Towards the end, you'll get a link in the chat box, as Anthony indicated, and there will also be a QR code that you can scan if you're attending via mobile. In terms of a disclosure, I don't have any financial arrangement related to the content of my presentation today. And I think as far as everything goes, we're all squared away with the University of New Mexico, the other things. That being said, these are my views. They are not the views, policies, or positions of the University of New Mexico. They're mine and mine alone, as are any errors and omissions that I make during today's talk. Brief bio, you already heard all that. Let's get to our objectives today. The first objective really is to understand where these courts came from, what's their origin, how they came to be, and where they came to be, and frankly, how they've spread. These and other sorts of similar courts, which are known by a number of different names. The second objective is to understand what these courts are supposed to look like, how they're to be implemented, what they're to include, what they're to address, how these courts go about identifying people who are appropriate to participate in them. And finally, we're going to talk about something that Anthony just touched on, and that's that this really does represent a very clear nexus between mental health issues and the court. And it's a collaborative endeavor. So we're going to talk about how these courts can potentially continue to assist to meet the needs of justice-involved and court-involved persons with various behavioral health disorders. Going to talk about the past, how that's happened, kind of where things stand, and also what might happen in the future. Finally, we're going to talk about some critiques of these courts because, frankly, they're not without their criticisms. Some, I think, are certainly valid. And we're going to start with one of those. One of the critiques of these courts, in terms of cultural considerations, is that they have not really established a great track record of enrolling people who represent all sorts of different ethnic, racial, and other categories. So All Rise, which you may not be familiar with that term, you may be more familiar with how they started out, which is the National Association of Drug Court Professionals, or the NADCP. They recognize this. They've developed something called the Equity and Inclusion Assessment Tool, and they've also developed associated resources that are to be used to address this very real problem. Similarly, American University, right in Washington, D.C., has developed a program as well to address these issues called the Racial and Ethnic Disparities Program Assessment Tool, or the RED Program Assessment Tool. You'll notice that those, you can find how to get to both of those because they're both footnoted. And at the end of the presentation today, I'll have a list of references, including the way that you can actually get these tools, which are both free to use and implement them if you do now currently or plan in the future to work in any sort of a treatment or accountability court. So start with some history. Where did these courts come from? Well, it started in the 80s, like so many great things did. We talk about the risk needs responsivity model, which really began in the 80s, all sorts of other things. And this began in the 1980s. It was actually put together by a couple of law professors, believe it or not, but they came up with not the drug court, but the underlying theory behind it, which is therapeutic jurisprudence. But the issue really behind both therapeutic jurisprudence, on which these courts are based, and treatment courts is that essentially our efforts to deal with illegal drug sales, manufacture, consumption, in terms of a law enforcement response, resulted in massive increases in arrest rates and in incarceration rates during the 1980s or since the 1980s. For all of the efforts, we really don't have a great deal to show for them in that they really haven't done what we had hoped they would do, and that is significantly reduce the availability and use of drugs in our society. So these types of courts arose in response and as an alternative to the traditional adversarial model of jurisprudence. So the first drug court actually was established in Dade County, which is Miami, Florida, called the Felony Drug Court. It was founded in 1989, so just at the tail end of the 80s. Interesting fact, the prosecutor in that court went on to later fame and in some cases infamy. It was Janet Reno. She was actually the prosecutor in this court before she went on to become the Attorney General. So as I mentioned earlier, the court was really based on the concept of therapeutic jurisprudence, which I'm going to abbreviate as TJ because that's a mouthful. And TJ provided the foundation for the court. TJ, or therapeutic jurisprudence, posits that, or the idea is that rather than have negative impact on people's mental health and psychological well-being, courts could actually, if they were run in a certain way, if they were affected in a certain manner, could actually improve the psychological well-being of persons who were court involved. And treatment courts, of which mental health courts are one variant, actually function as therapeutic jurisprudence in action. Since 1989, since the first court was established down in Miami-Dade County, these courts have proliferated, and there's many, many different types. We're going to talk about mental health courts today, but mental health courts are only one of the many types of treatment courts that exist currently. We have adult drug courts. That's what the first one was down in Miami. We have DUI courts, veterans treatment courts, family dependency treatment courts, where often the court is initiated through Child Protective Services rather than through the courts. We have tribal healing and wellness courts, human trafficking courts, opioid courts, and that's just a sample. We have all sorts of juvenile courts. These courts have taken on many different flavors since they were initiated back in the 1980s, and they have a bunch of different names. They are alternatively referred to as treatment courts, accountability courts, specialty courts, problem-solving courts, or alternative courts. It doesn't really matter to me what name you use. In Georgia, where I work primarily, they're known as accountability courts. We have a rather conservative state politically and in terms of our judiciary. And one of the concerns about these courts when they first came about is that they were a type of hug a thug, and that it was being soft on crime. And of course, that wouldn't go over well. So calling them accountability courts, ensuring that we really focus on the word accountability, holding these individuals accountable while at the same time providing treatment and a lot of other ancillary resources was really going to happen. And it has happened. We have almost 200 of these courts here in Georgia. And what they all have in common, despite there being different ways that people come into court, different types of charges, different types of behavioral health disorders or issues like child neglect or abuse, they all have in common that they use an alternative way of doing business. They process cases very much differently than the traditional adversarial approach, and that what they do is instead apply a collaborative, multidisciplinary approach. So these courts bring together teams of individuals from different agencies, from different backgrounds, different training, different types of degrees, and together they all have the same goal, and that's to address the issues that got the person or persons into court. And the goal really is to stop the revolving door by tackling those root causes and conditions that result in repeated involvement in the criminal justice system. There's an analogy you may have heard. These two individuals were sitting by the side of a river having a picnic, and they noticed that someone was floating down the river calling for help, needing to be rescued. So one of them ran down, pulled him out of the river. 5 minutes later, another person came down the river. So the guy ran back down, pulled him out of the river. Happened a third time. The guy ran down the river. The other guy ran upstream, and he said, I'm going to not pull people out of the river, but I'm going to figure out why they're getting in the river in the first place. That's essentially what these courts were designed to do, is address the issues, the root causes that resulted in people being brought before the judge again and again and again. They're also, in addition to being based on the therapeutic jurisprudence model, they're based on the underlying premise of the risk needs responsivity model, which, given some of the topics that have come before me in this series of seminars, I imagine most of you are aware of. And that is that it's important and critical, in fact, if you want to reduce recidivism, to effectively identify, target, and address criminogenic needs. And doing so really is the best bet to reduce recidivism. So since 1989, since the first felony drug court was begun in 1989, we now have over 4,000 of these courts in the US and in a number of other countries. Every single state has at least one of these courts, and many federal districts also have at least one of these programs. They found to be effective in terms of reducing recidivism and costs, but there's a caveat here, and that's that they're effective to the degree that they demonstrate fidelity to the model, to the treatment court model. And we're going to talk a good bit about what that model looks like as we move along today. In fact, we're going to start right now. We're starting now to talk about, all right, so you said these are different. How are these courts different? We're going to address what are called the 10 key components. Now, initially, these were put out by the Bureau of Justice Assistance and the National Association of Drug Court Professionals, now known as ALRISE, quite a while ago, back, I think in the mid-90s. And they laid out the 10 things that were necessary. Basically, they established a baseline that these types of courts had to have if they were to be considered treatment courts, or in those days, when most of them were drug courts, drug courts. So I've changed them up a little bit to apply just to mental health courts. And I'm not going to spend a great deal of time on these. You will have access to these slides, like you'll have access to this recording later on, but we'll go through them briefly. The first one, planning and administration. Earlier, I had mentioned that these courts are predicated on the fact that there's a multidisciplinary group of stakeholders, of people with a vested interest in addressing the issue that represent a bunch of different agencies and a bunch of different viewpoints, frankly. So we've got criminal justice folks, mental health folks, substance use, treatment folks, as well as people that represent all sorts of ancillary needs like job training, education, housing, food assistance, all sorts of different things. So there's a broad-based group of folks. Oftentimes, these groups form a steering committee or a steering group. Next, we've got the target population, and that eligibility criteria are set and they're adhered to. That doesn't mean there's no exceptions to that, but essentially it's pretty well laid out for the different types of courts as to what sorts of individuals are appropriate for that court. One thing is fairly consistent though across them all, and that's that in accordance with the risk needs responsivity model, we're looking for individuals who demonstrate at least a moderate and likely more high risk and high needs. So that's our target population. And for mental health courts, which is what we're talking about today, we're talking about people with serious mental illness or serious and persistent mental illness. Oftentimes, something like major depression, bipolar disorder, schizophrenia, those sorts of things. A few of the other 10 key components, timely participant identification. One of the things we found is that the quicker we can get people into courts, the better that they fare. If they're kind of out there, if they've bonded out and they're out in the community and they're waiting weeks or months to enter the court, that's not good. So the goal oftentimes is to shorten as much as possible the time between they're identified as a potential participant and the time they enter the court. Optimally, that would be 30 days or less. In terms of participation, it's clear most of the courts that I've worked with, and I've worked with quite a few of these courts over the years, they have participant handbooks where those are given to participants, and it's very clear as to what the participant can expect, how they address issues, what sorts of treatment they can get, all those sorts of things. Informed choice. It's really important that people know what they're getting into. It's much like the informed consent process that many of you likely go through when you're conducting a forensic evaluation, because there is a deprivation of liberty issue at stake oftentimes, and that if people in the court don't necessarily follow the rules, they could be removed from the court and sent back to typical court, or they can have jail sanctions, although those thankfully are decreasing over time as we find that they're not really all that helpful. Treatment supports and services, that's all sorts of different things that are provided. Oftentimes it depends on what's available in the community in terms of a continuum of care. So the court has to make sure as it's getting underway and as it's providing services that there's enough continuum of care from the different levels of treatment available in the community to meet the needs of participants. Confidentiality, I mentioned earlier that sometimes these individuals, if they don't necessarily go by the rules, if they don't do what they need to do as part of the court, they can be sent back to typical court. Well, we want to make sure that if that happens, all the stuff that came out in court related to their behavioral health disorders doesn't follow them. There are federal regulations around that. There are HIPAA regulations that need to be abided by to protect the confidentiality and the privacy of participants. The court team, I alluded to that earlier. The court team is smaller by definition and typically made up of clinicians. It's smaller by definition than the advisory committee that I spoke of earlier. But these are the folks who are actively involved in providing evaluation, treatment, and ancillary services to participants. They typically meet weekly or every other week in what's called as staffings, where they discuss cases before the actual court hearings. And the last two, monitoring adherence to court requirements. These are, after all, courts, and courts operate by certain rules. So it's important to ensure that the court is recognized as the housing of the program and that the court's rules, the rules that are specific to that jurisdiction or that state, are upheld. And finally, sustainability. A lot of these courts got started or initially got support via federal grants. It's important that the courts, of course, continue after the grants go away. So sustainability is important. And since the beginning of these programs, there's been an emphasis on collecting data and, in fact, ensuring that there's ample opportunity to demonstrate that these courts do what they say they're going to do. When they first started out, oftentimes they were met with suspicion. And one way to counter that suspicion is to address the degree to which they do a couple things and do those two things fairly well. And that is to reduce recidivism. And the second is to improve costs, so to increase cost effectiveness. So those are the 10 key components. Those are the baseline. That's kind of like the floor. If you don't have these 10 key components, or if your court doesn't have these 10 key components, or even is missing 1, 2, or 3 of them, you may not actually have a treatment court, because fidelity to these 10 key components is critical in order for the court to achieve the objectives that it set out to achieve. So that's the floor. All Rise also has what are called the best practice standards, which are aspirational, and they describe courts that are functioning optimally. So you've got the 10 key components at the bottom. That's the baseline. That's kind of the floor. The ceiling would be the best practice standards, which were recently revised, in fact. And all of these are available free of charge through the internet. So we've got the floor and we've got the best practice standards. Most courts are operating somewhere in between. And I've been to lots of courts. I've probably been to over 100 of these different types of courts. I've never seen a perfect court. I don't think that's because I've just somehow missed it. It's because there is no perfect court. There's no such thing. So courts can always improve. These treatment courts can always do better. And the best practice standards are, frankly, what they ought to be aiming for. So forensic psychologists, what role can we play as forensic psychologists or psychiatrists in these treatment courts? So there's a number of different ways they can get involved. And I will say I actually do serve on a mental health court in Georgia as the evaluator. And by evaluator, I'm not the person that does the evaluations of every single participant. I evaluate them to ensure that they're meeting their objectives based on a federal grant we got about 15 years ago, and I'm still there. So what can we do as forensic professionals in these sorts of courts? I'm going to refer you to the parenthetical references. KC, that's key component. So key component 1, we can serve as part of the planning and administrative team that's referenced by key component 1. We can also assist in identifying, developing, implementing the eligibility criteria to make sure that these courts are in fact serving who they're designed to serve. And that is individuals who are assessed and who demonstrate high risk and high needs. And by high risk and high needs, I'm referring to what we understand high risk and high needs to be relative to the risk needs responsivity model. And by high risk, I'm not talking about risk for violence or risk for dangerousness. I'm defining high risk as risk for continued involvement in the criminal justice system. The third thing we can do is help to link participants using validated assessment tools to provide diagnosis and referral to appropriate services, treatment, and otherwise. We can also help provide treatment, supports, and services, including something that has been really these courts since the very beginning, and that's contingency management. There are oftentimes what are called sanction grids, incentive grids, graduated sanctions, graduated incentives. It's really all contingency management. And finally, I think that forensic professionals can be involved in that sort of final 1 or 2 things, 1 or 2 key components. And that's making sure that the court adheres to the requirements set before it and is also working to meet its objectives. And that's my role as a forensic psychologist with the mental health court that I work with. Another thing that I think is attractive to folks who are trained in a clinical setting is that the collaborative, collegial setting of these courts, the fact that they're evidence-based in terms of what they're implementing, the idea that the goal rather than to continue to perpetuate the revolving door, is to address the problems, the issues that got the person into court, oftentimes that got them in trouble again and again and again. That focus is appealing, and it provides a collegial atmosphere and an approach that is in stark contrast to the typical adversarial approach of traditional court processing. So that's another thing that I think is really attractive. I know it's been good for me when I talk with individuals, in particular judges, who've presided over these courts. They say it is the most rewarding part of their professional careers. I also mentioned therapeutic jurisprudence. The idea that the court itself can function as a means of providing for increased psychological well-being and increased mental health. Most people that come before court in a traditional setting, they probably say that's the last thing that the court resulted in, that they felt worse, that they felt traumatized or re-traumatized if they have a history of trauma. So the idea that these courts further and in fact can improve people's well-being in terms of their mental health, it appeals to folks with clinical backgrounds. And finally, I think these courts provide a means by which we can apply our clinical acumen, our clinical expertise, whether it's in evaluation or treatment, some combination thereof, an understanding of the intersection between law and mental health, which I think is why a lot of us are here. These courts provide a really great opportunity to address those issues. Another thing, I don't have it up here as a point, but I was doing a training for about 80 prosecutors last month. And I asked how many of them were familiar with therapeutic jurisprudence. I thought I'd get at least a few hands. I got none. Nobody in that group of 80 prosecutors was familiar with therapeutic jurisprudence. Only a handful were familiar with the risk needs responsivity model. I asked them if they ever heard of therapeutic jurisprudence in their law education. None of them had. So I think another opportunity for forensic professionals like ourselves is to be able to provide some exposure and some education to court personnel in terms of therapeutic jurisprudence, risk needs responsivity model, and other sorts of things that are relevant to these courts. How we identify mental health court participants. Earlier, when we talked about the 10 key components, I mentioned that there are inclusionary, exclusionary criteria because we want to make sure we get the right people in the right courts, and that we provide assessments that are validated, which really is a specialty of probably almost everyone in attendance today, that we make sure that we have documented and objective criteria for eligibility. It's not just someone saying, yeah, I think this guy is going to work out just because I got a feeling. It's based on objective criteria that in fact are documented in the protocols that the court operates by. It's also important to make sure that the court falls in line with what's going on locally in the local legal community and the local judiciary. I had mentioned the risk needs model, the risk needs responsivity model earlier. We know through lots of research that these courts demonstrate the greatest bang for the buck, the greatest degree of benefits when they do in fact enroll people that are assessed as demonstrating high risk and high needs in line with the risk needs responsivity model. And we know based on the risk principle, the needs principle, the responsivity principle, that the greater the assessed risk, the more intense and lengthy the intervention. These courts are not short. Oftentimes participation in a mental health court, in order to get all the way through the court from beginning to end, it's oftentimes 24 to 36 months in length, because we're talking about high risk, high needs people who present with very complicated and complex issues. It's important that we also, in terms of being in line with the risk needs responsivity model, that we target assessed criminogenic needs. So doing a comprehensive, ongoing process of assessment and evaluation. It's not enough just to provide screenings at the beginning. We've got to do ongoing assessment due to the difficulty associated with correctly identifying and diagnosing the various issues that are being presented by the participants. We know that There's symptom masking, symptom precipitation, symptom mimicking, taking the time necessary for persons that have abused substances like methamphetamine for the cognitive fog to lift, for the long-term effects on brain chemistry and brain function to resolve. We know that this requires ongoing assessment over time. One of the things that I found, and I think All Rise is also very well aware of this issue, and that's that irrespective of the type of court, and earlier on one of the slides I had up a whole bunch of these different types of courts, irrespective of the type of court, there's a great deal of commonality in terms of the issues being presented across the different courts. One of those is co-occurring disorders, and that what we find is that whether it's a drug court by name, a mental health court, a family dependency treatment court, veterans treatment court, there's a very high likelihood that at least half, and oftentimes more, of the individuals who present as being eligible for these courts, they actually present with co-occurring disorders. This is a challenging population. These are folks who have serious substance use issues, substance use disorders, as well as serious mental health issues. And we know from research on this group that these are folks who are less likely to complete treatment. They have higher rates of relapse of symptoms after treatment, higher rates of rearrest and other undesirable outcomes. Another reason for that is because we really haven't done a great job addressing the needs of persons with co-occurring disorders. I remember it wasn't too long ago when I would have someone presenting with a co-occurring disorder, and I was really flummoxed as to where I could find appropriate treatment. I would call a substance use disorder facility, and they would ask me if the person has a mental health disorder in addition to the substance use disorder. And if I said yes, they'd say, I'm sorry, we can't help. Likewise, if I called a mental health treatment facility, they would ask if the person has a co-occurring substance use disorder. If I said yes, they said, sorry, we can't help you. That's changing now, but we have a pretty poor history of effectively addressing persons with co-occurring disorders. Similarly, we're finding that irrespective of the court type, individuals have many of the same common issues. They have poor education, poor family histories. They've got poor employment histories, unstable housing, all sorts of things. And really, if we took 100 people participating in many different types of courts, put them all in the same room, we wouldn't be able to tell them apart. And All Rise is essentially acknowledging this by saying that, well, we're finding that this is the case. And we're now just basically, rather than saying, oh, let's talk about an adult mental health court, let's just talk about treatment courts, because the commonalities of the individuals being served by these courts outweigh the differences. Now, that's a little different in some of the courts, like family dependency treatment courts, where typically the person enters the court through a petition brought by Child Protective Services. But generally speaking, even those individuals experience many of the same challenges. So what do these courts look like? Well, you'll be happy to know that oftentimes the courts require the use of evidence-based practices. And these are manualized treatment programs. You've likely heard of many of them. There are programs for all sorts of things that address substance use disorder, mental health disorders, unhealthy thinking patterns, criminogenic needs, in other words, looking at those central 8 factors. Also, of course, medication management is a huge issue given the need to effectively treat serious persistent mental illness. Group and individual treatment, support groups in the community, typically psychoeducational interventions. But in addition to those specific treatment components, there's a whole bunch of different ancillary components as well, many of which I mentioned earlier, but you can see there in that list. So these are folks who, because of their complicated issues that they've been confronting, they've got issues with housing, public benefits. Oftentimes, for instance, if they go to jail, their Medicaid is cut off. Many of them might qualify for Social Security disability insurance because of their mental health issues. Surveillance in terms of assessing, making sure that these individuals are where they're supposed to be at the right time. Judicial monitoring, that's a huge part of these courts, where typically they go before the judge in the early phases of treatment, and most of these programs are phase programs, so there's typically anywhere from 4 to 6 phases that people progress through. They also are subject to regular, frequent, random drug screens. Another very helpful adjunctive strategy to these types of programs, in particular, mental health courts, is including people with lived experience, peers. And NAMI, which is the National Alliance on Mental Illness, is a huge source of assistance in this area. And as I mentioned earlier, the typical participation is 2 or 3 years, which is a long time. It oftentimes would have been less time intensive if the person would have just chosen to do some time in jail. But the idea being, let's actually work on the issues that continue to result in criminal justice involvement. How do people get into courts? Many, many different ways, really depends. I've worked with courts that are strictly pre-adjudication or post-adjudication. Most of the courts I work with, though, the folks get in any number of different ways. So they can be enrolled pre-adjudication, so it's a diversion or a deflection, post-adjudication, where it's at the end of the process of adjudicating the charges. However, it's possible the charges may be expunged later, or violation of probation or parole, or being transferred from another court. One of the things that really typified these programs early on was that they excluded people with either a current or a prior violent offense. Thankfully, that's not the case as much anymore. It arose because of limitations in federal funding. Essentially, Congress did not want federal funds to go towards treating what they referred to as violent criminals. And therefore, for many years, if you got federal funding, you couldn't have anyone participate in your court that had either a prior or a current violent charge. That is thankfully changing. We found in terms of the research on these courts that people with violent charges do just as well in terms of reduction of recidivism and increased cost effectiveness. And in particular, persons in mental health courts, as well as veterans treatment courts, are more likely than those in other types of courts to have either a current or a history of violence. And typically what happens is the circumstances of that violent charge are looked at very closely in the process of identifying if the individual is a good fit for the court. So it's kind of a case-by-case basis. And earlier I mentioned contingency management, incentives and sanctions. They're just as effective with mental health court participants, as they are with anybody else. We all are subject to the laws of behavior. So you'll find that using appropriate sanctions and incentives are just as effective when you're working with a mental health court population. So what does the research say? Do these courts work? Well, in general, yes. In fact, these types of courts, treatment courts, are probably the most well-researched of all criminal justice interventions. Thousands of articles have been written to address the degree to which these courts meet their objectives. So when we talk about these courts in general, yes, we find that evidence exists that these courts, treatment courts in general, do reduce recidivism and they result in cost savings. What about mental health courts? Well, it's not quite as clear-cut with mental health courts. They haven't been around as long as drug courts, but what we do know is that the evidence suggests that mental health courts are more successful at reducing recidivism than they are at resulting in long-term improvement of mental health symptoms. Now, that, to me at least, makes perfect sense. There is no means by which we can cure schizophrenia. There's no means by which we can cure bipolar disorder. And really what we're looking for is a type of harm reduction, and that we want to increase the amount of time between relapses and decrease the amount of time spent in a relapse state. That's probably the best we can hope for. There's also evidence, albeit somewhat limited evidence, that these courts reduce subsequent police contacts and jail bed days. And really that's a critical thing to remember, because if you've ever worked in a jurisdiction, you know that there's a subpopulation of persons with behavioral health disorders who are very well acquainted with the local law enforcement and may have a rap sheet that's 25, 30, 40, even 50 pages long. So by participating in a mental health court, there's limited evidence that we reduce those criminal justice contacts and the days spent in jail. And we all know that jail bed days are very, very expensive. In fact, in many jurisdictions, the jail is really the most important user, or the biggest user oftentimes, maybe not most important, but the contributes significantly to the budget of the local community. In terms of cost benefit savings, those results are mixed as well, and that some studies have found that it takes years to recoup the costs. And that's because this treatment is not cheap. It's expensive. Difficult issues we're addressing. So essentially, it takes quite a while. Some find that, or some studies of cost effectiveness have found that these really don't return financial benefits to their communities ever. So that's an open question. Whereas with these courts in general, in particular with adult drug courts, they have demonstrated cost effectiveness. So some critiques. What are some of the criticisms of these types of courts? We had mentioned one earlier, and that is that, and it's certainly valid to the point that All Rise, which essentially is the organizing body that is involved in this work around the world, has acknowledged that they have not historically done a great job of ensuring that people get into the courts who are representative of persons arrested for the charges. So really the idea being that these courts have not effectively represented the community to the degree to which they should. And All Rise, as well as American University, who provides a lot of training and technical assistance in this area around the country, they've addressed this, and they've come up with a couple different means of addressing diversity. One of the ways that I've done that, it's pretty simple. Well, if you have access to the data, that is, and that is to look at the number of people arrested in your jurisdiction on the types of charges that typically result in referral to these courts. So you get the number and characteristics, racial, ethnic, gender, those sorts of things, the characteristics of the persons that typically are arrested for charges that find their way into your court. Second, look at the group that are referred to your court along those same characteristics, the race, ethnicity, gender, education of the persons that are referred to the court. The third group you look at, those same characteristics, are the people that enter the court. And finally, look again at those same characteristics in terms of the graduates of the court. And if people look different at any of those 4 points of contact, you probably have an issue, right? So that's one of the ways to look at this. So for instance, if the appropriate individuals are not being referred to the court, and that those referred are not reflective of those arrested for those charges, well, you've got to look at your referral sources to address that issue. If the graduates look different in terms of their race, ethnicity, and other personal characteristics from those that are brought into the court, well, then that's a court issue. What issue or what bottleneck is preventing folks from graduating to reflect the same population that came into the court? So that's a pretty big issue. Another issue, a criticism that has been levied at these courts, is that they don't really provide an effective alternative to incarceration, because what they do is they increase the number of people in the community under correctional supervision. And because of that, because they're being watched, if they're being watched more closely, more opportunities are going to present themselves to observe wrongful behavior, that they're going to actually, rather than decrease criminal justice engagement, they're going to increase it. So those are a couple of criticisms. They're valid. They're things we got to look at. The last thing that we want to do is increase the reach and the depth and the breadth of the criminal justice system in terms of wrapping people up, because once you get in, it's not easy getting out, right? So we want to take a good look at that. And we are looking at addressing issues of diversity and actively ensuring that these courts represent a more diverse population than they have historically. Oops, sorry, went too fast. Okay, here are the references. They're available by and large on the web. A couple of them are articles. No need to go through them here, but you can get the slides and you can actually plug these in or copy and paste them into your web browser of choice. And these are all essentially noted in the actual slides themselves. All right, I've got about 13 minutes for questions. I'm going to ask that Anthony go ahead and tell me what those questions are. This is I think this is the QR code that you can use to get the evaluation and complete the evaluation to get your CUs. So Anthony, I'm throwing it back to you. Any questions at all?
Yeah. So far, we certainly do. Thank you so much, Dr. Baldwin, Kevin, for that thorough overview of mental health courts. Yeah, like we said, this is a very, very critical issue in that intersection of mental health and legal systems. So I think it's very helpful for people to have this foundation, and thankful for all the work that you do in this area. We do have a number of questions already. As Kevin noted, the QR code there for the CEU survey if you want, and also there is a direct link in the chat box as well. We do have a number of questions. Somebody has asked about broadly how you view the exclusion of those with intellectual disabilities from mental health courts.
Yeah, boy, that's a great question and a real issue. And that if we're truly going to meet the needs of as many people as needs these courts, basically there's a huge need. We've got to be able to address that. So that gets to the responsivity of these courts, the second R in the risk needs responsivity model. And that is that if the person has a demonstrated intellectual disability or a learning disability, we need to be able to provide the manuals in a way that essentially accounts for that. So whether it's by assigning a peer to them who can help tutor them, whether it's providing materials that are suited to their assessed level of disability, we've got to make sure, to the degree that the court is able, that we don't let intellectual or learning disabilities be a barrier to getting into these courts. Relatedly, we know that a large portion of individuals in these courts, but in the criminal justice system in general, have experienced head injuries, which has resulted in measurable deficits in their ability to effectively process information. So to the degree that which we can, we've got to make sure that we're responsive to the needs of those individuals. Now, there's nothing we can do intervention-wise to reverse those deficits, but there are things we can do to accommodate individuals based on their capacities, so that we can increase the degree to which they could actually complete the course.
What are some examples of the contingency management incentives or sanctions that you referenced?
Great question. Let me turn my alarm off. Yeah, typically one of the ones that's used most often is a fishbowl. So it's a literal fishbowl, and the kind you have like a single goldfish in, not the huge big thing. But it's on a table in the courtroom, and when participants have a specific accomplishment, so let's say they've been 90 days drug-free, or something to that effect, they're able to pick from the fishbowl, and in the fishbowl are all sorts of different pieces of paper that indicate incentives. So something might be like a $10 gift card to Walmart, or they get to leave court early a day, or something like that. There's a huge range of them. And if you go on the web, you'll actually find resources like All Rise has resources for a great many types of incentives and sanctions. As far as sanctions, thankfully, these courts are moving away from jail sanctions. Maybe 10, 15 years ago, jail was like the default sanction. So if someone messed up, boom, 2, 3, 4, sometimes 30 days in jail. We now know that that is counterproductive, that it has a very pronounced destabilizing impact on someone's life. And thankfully, courts are moving away from that as a sanction. But other sanctions might be community service, or having to attend some sort of something or other that would be not fun, but it wouldn't take them out of their efforts that they're engaged in to create an effective community of sober individuals and to have the kind of residence stable and work stability that actually goes towards success.
Thank you for that example. Someone just added about their own courtroom. One thing our courtroom does is a spinning wheel with incentives like gift cards, Zoom court, exclusions from court. All participants that are in compliant for the week get to spin the wheel and get that incentive.
Yeah, it's like the Wheel of Fortune. That's
Mhm.
pretty cool. I've seen that, and it's it's a little more dramatic than a fishbowl, that's for sure. It's very nice.
Just a little bit, yeah. Can you comment about the criticism that the outcome data is not representative because of selection bias, that those who meet the inclusion criteria tend to be at lower risk than those who aren't eligible for mental health court?
So I think that question might get to the criticism of cherry picking. And that certainly was the case early on in these courts, that oftentimes the referral was based on the idea that, hey, this person, he or she is likely to benefit and likely to be a good compliant candidate, so let's get them in the court. Well, that's really been replaced by a mandate to enroll people in these courts that are demonstrating high risk and high needs. For instance, in Georgia, it's written into our legislative codes that establish these programs that they have to use a validated, normed assessment of risk and needs, and they have to basically put people in these courts that are moderate to high risk and high needs. And that kind of argues against the whole selection bias. The reason being is that we found that research, not just with treatment courts, but the R&R research in general, very strongly indicates that the more high risk folks that we bring in, the more likely they are to benefit from treatment. And in fact, if we put low risk folks in, we can overprogram and we can actually make it more likely that they're going to recidivate. We can do more harm than good by enrolling low risk, low needs people in the intensive types of programs typified by these courts.
How do you assess for the inclusion of personality disorders?
Great question. One of the things that I do is I typically look at the results of a personality and psychopathology measure. So the MCMI, the PAI. Not many courts that I'm familiar with use the the MMPI. It's just very long. So that's how I do it. Other courts oftentimes administer more screeners, more personality screeners. They also, like for instance, in Georgia, just as where I'm most familiar, we use the LSI family of measures. So currently we use the level of service inventory case management. So the LSCMI, that doesn't necessarily get at personality issues because it focuses on the central 8 risk factors as identified by Andrews and Bonta. But oftentimes when you look at those things, you can find out things that correlate well with some of the types of personality issues we're likely to find in these courts, like antisocial personality disorder, those sorts of things.
Do you know of any models for these courts that are directed toward children?
Not necessarily children, but there's a lot of adolescent courts and juvenile courts. There are quite a few juvenile drug courts, juvenile mental health courts, where essentially people who are underage, and in Georgia, our age of criminal responsibility is 17. So these courts are populated by kids as young as 11 or 12 and going up to age 16. They may turn 17 while they're in the court, but there's quite a few courts around the country that are addressed to juveniles. In terms of the research record, one of the things that plagues courts, unfortunately, that provide service to juveniles, fidelity is sorely lacking. These courts are the Wild West in terms of what they look like. So we've got to do a better job. There's no 10 key components specifically for juvenile courts, but in Georgia and elsewhere, there is a good deal of movement to bring these courts, juvenile courts, more into line with what we know works with juveniles. So implementing things like multi-systemic therapy, functional family therapy, those sorts of things as the evidence-based programs that the courts provide.
I think understandably, a lot of questions and a focus are on inclusion criteria, or how do we get more people involved into mental health courts. Somebody asked on the flip side, what mechanisms are in place in mental health court to identify and remove individuals who have been inappropriately placed in that setting?
Yeah, boy, that is a huge issue. We find it with all sorts of different courts, and it's because of something I mentioned during the presentation, and that is that it's really difficult to do an appropriate differential diagnosis at the point someone's assigned to the court. So that's due to the symptom masking, symptom mimicking, the brain fog brought on by chemical intervention through drug use. So it's often the case that 2 or 3 months, sometimes 6 to 9 months in, we'll find that this person is actually a better fit for another type of court. Well, then you've got to go through the whole process of them starting over. So what All Rise is doing is they're really recommending that folks take a broader view. And instead of thinking about, well, that we've got an adult drug court and then we've got an adult mental health court and we're going to keep them separate, the idea is to acknowledge just what is prompting the question, I think, and that is the sense that these individuals often present with a host of issues, and rather than restricting the court to address one particular issue or another, the understanding is that we've got to have courts that are broadly equipped to treat a bunch of different behavioral health disorders. And therefore, the movement is towards treatment courts rather than identifying the specific court you refer someone to based on what you think they need at the point of entry.
Wonderful, thank you. And as we wrap up, someone asked if you could talk about the federal grant that allows you to do the work you do with mental health court. If we wanted to approach our local mental health court with the idea of putting a psychologist on the assessment team, how would we go about it, given financial constraints would be one of the main barriers?
Oh yeah, definitely. There's a couple of granting agencies that every year put out millions and millions of dollars to these types of courts. The first one that I'd recommend you look at is SAMHSA. So the Substance Abuse Mental Health Services Administration. They fund all sorts of these courts all over the place. So SAMHSA is a great place to look. And every year in the spring, it's just kind of like gardening. That's when the seeds are planted. So the announcements, the funding announcements come out. So SAMHSA puts out a bunch, and then BJA, Bureau of Justice Assistance, they do as well. So the primary means by which I've been supported to do this kind of work have been either through SAMHSA or BJA, and in a few cases, what's called braided funding. So these are funding opportunities that come through SAMHSA and CSAT or CSAP, which is the Center for Substance Abuse Treatment and the Center for Substance Abuse Prevention. Grants come out in the spring. I have people contact me, typically the coordinator of the court will contact me. A lot of these grants require external evaluation, thanks to what's called GPRA, which is the Government Performance Result Act. It says basically if the feds are going to give you money, you've got to demonstrate that you use that money to pursue the objectives that got you the grant in the first place. So they often have 10 or 15% dedicated towards evaluation, data collection, that sort of thing. And I'm in my 16th straight year of being very fortunate to have funding from one or the other of those organizations to do this kind of work. So generally speaking, that's where the funding comes from. If you have specific questions, by all means, reach out to me. I'd be happy to send you some examples of the funding announcements that come out, so you'll know what to look for and when they come out.
We are at the top of the hour. So Dr. Baldwin, Kevin, thank you so much. Really appreciate you on being just a well of knowledge here in terms of mental health courts, and your willingness to share both the evidence, the info, and just how these would actually play out and the impact that mental health courts can have on our society. So thankful for sharing all of your expertise with us today. That
It's been a pleasure, and I'm honored to have been asked. So thank you so much.
Certainly. That wraps up this week's Law and Mental Health series. Next week, we have Dr. Mina Rutkalkar, who will be discussing practical strategies for enhancing cultural responsiveness and forensic assessments. We hope to see you then for another great discussion of issues in behavioral health and the law. Until next time.